So this is just going roughly over the physiology and management of hypoxia again, but as I said, I'm going to be taking this a step further. So do stop me if there's anything that is not clear, and I will try and check and make sure that you're following all the way through. So the idea is, once again, an overview on the physiology and how to manage the different features of each type and how to manage them. Okay. We always talked about the difference between hypoxemia and hypoxia. Hypoxemia, low oxygen in blood. Hypoxia, low oxygen in the tissues. We are concerned about hypoxia, not hypoxemia. Yes?
Yes.
So the reason being is that hypoxia is the damaging element. Hypoxia is what causes brain damage, causes tissue damage, causes heart failure. Okay. So 4 types of hypoxia we always discuss: acute, subacute, gradually evolving, and chronic. And we'll always start with acute hypoxia. What's acute hypoxia? So it presents on the CTG with a prolonged deceleration, but what is it? What happens in acute hypoxia? The baby's oxygen supply suddenly stops for various reasons, okay? And the baby is literally getting no more oxygen. Just out of interest, how much oxygen do you think is within the the oxygen carrying capacity of the entire baby's blood volume? Can anyone take a guess? If the baby's hemoglobin is 100% saturated with oxygen, every single drop of blood, how much oxygen do you think it can carry?
Yeah.
90 milliliters. So the entire 3.5 kilogram baby, it's not carrying 90 milliliters. That is the 100% oxygen carrying capacity of its blood. The reality, most of the time, baby has about 30 milliliters of blood within its system at any given one time. The baby consumes about 0.5 milliliter per beat. Okay, so basically the baby can consume most of its oxygen within its system within about, can anyone do the maths? 60 beats, yeah, 0.5 minute. So in 0.5 minute, if you stop the oxygen saturation supply to the baby's body can literally consume the entire oxygen content of its blood within 0.5 minute, okay? But obviously that's not what happens. If you stop the oxygen supply to the baby starts using anaerobic metabolism, it starts redistributing blood from its periphery. So the baby's heart and brain consumes about 4 milliliters per minute, up to 14 milliliters per minute, depending upon its oxygen, its metabolic rate. So again, that is quite a lot, considering that baby only has 30 milliliters of oxygen in its body. Okay, so we say that the pH drops at 0.01. That is because most of baby's body has suddenly gone into anaerobic metabolism. So it's producing lactic acid and using up breaking down the glycogen, yeah? So that produces a lot of acid just to try and maintain some of the oxygen. Most of its body clamps down quite fast. So it can reshunt, or it can shunt all the blood from the periphery to the central nervous system and heart pretty fast, okay? It basically just needs to start filling up the left ventricle in favor of the right, and it can do that, okay? But the issue is fetal pH drops at 0.01 per minute if this is a normal baby, this is a non-hypoxic baby. If the baby starts off with a chronic hypoxia, so it already only has 5 milliliters of oxygen in its blood, okay? Or it's already been redistributing for a while. Do you think the pH is going to drop at 0.01? It's going to drop at a much faster rate. If the baby starts off with sepsis, with a high metabolic rate, so baby's brain and heart are already consuming a lot of oxygen anyway, yet still producing more acid, the pH is going to drop much, much faster. So a colleague of mine texted me a CTG over the weekend, okay? And the baby had acute hypoxia for 7 minutes. Literally 7 minutes. It dropped its pH by about 20, so 0.2 within the 7 minutes, because this baby was already septic. Thank God they managed to get there in time. Thank God the baby was fine. But the reality is, it only had 7 minutes to drop this pH that far. How do I know that it dropped it that far? Because I looked at the venous as well. Does that make sense? Are we still there?
Yeah.
Yep.
Okay, so management of acute hypoxia is something that we need to do quite rapidly. We divide the causes into two: the irreversible causes, the ones that we can't do anything about, and the reversible causes, the ones that we can, that generally we are the ones that cause to start with, and the ones that we can actually reverse. Okay, this is a flow chart. I don't know whether you can actually see this. Can you see it clearly? So we start off with the acute hypoxia. The deceleration is lasting over 2 minutes and there's no signs of recovery. You pull the buzzer. You're aiming for your team to be there within the 3 minutes. You start assessing the baby. You're looking for the cause of the hypoxia, and you look for the fetal reserve and signs of recovery. Looking for fetal reserve is a very important part. If you look at the trace before, and you can see that the baby was already hypoxic, or that you can see that their baby is already showing signs of reduced reserve, so the baby's variability has gone flat, okay, you know that baby's brain is becoming ischemic from the very beginning. This baby does not have a lot to lose. This baby cannot spare its oxygen anymore. Okay, this baby's going to get damaged regardless of what the cause is. So just deliver that baby. Don't try and correct that. Yes, try and make it better on your way. So if she has a prolonged contraction, stop it. But get her to theater as soon as possible. So terbutaline can still be used. I'm not saying don't use it, but use it while you're on your way to theater, rather than use it and wait in the room, because you are losing very, very precious time. If it's a reversible cause and the baby is showing good signs of reserve, that's when we treat and we watch. Does that make sense? Okay. Signs of baby getting worse. So what would I see on the trace of the baby is getting worse? I need volunteers to answer. Otherwise, I'll start picking names.
Variability.
Variability. Okay. What does that tell you?
Again, that there's the brain's becoming more hypoxic.
So the brain is becoming ischemic. Okay. What about the actual rate?
As in
So
baseline.
variability. So the heart rate will actually start getting slower. If the ischemia is getting worse, if the hypoxia is getting worse, the heart rate will start getting even lower and the variability will go off. If the baby is improving, the first thing that comes back is the variability again. So the baby's brain starts getting some more oxygen. If the brain doesn't come back, can this baby recover from this hypoxia? The answer is no. There is no way this baby can recover, simply because the moment the brain is gone. Hi, Susanna.
Ahmed, hi.
Hi.
I'm going to challenge a little bit on that. I think that it's very important to look at the variability. I think so. When the baby, when there is this ischemia, I don't think that we can say directly from the variability. So, and that's why in a way, that's how SAN, not for acute hypoxias, works beyond our eyes. So usually the problem with the brain in these situations is actually hypotension. it's and you can have reduced variability in brains that recover. So the capacity to, so when you say ischemia is dead, it doesn't come back. Yeah. And when you say hypoxia, there's a period of hibernation in so it's when you say absent variability, it doesn't mean always ischemia. So that's why some people then are very afraid of these acute hypoxic events and ask, oh, but we've killed already the baby cells. No, you can have safe, I mean, you can have these episodes that are harmless, that you don't produce harm. The important thing for us is to distinguish what are the things that you can reverse, and you reverse as quick as you can, and the things that you can't reverse, so don't lose time, just deliver.
Okay.
Would
So
you
that's
agree?
not what I was saying. So I understand that acute hypoxia doesn't necessarily mean that we've just killed the baby's brain. What I was saying was that the first sign of improvement of the baby's acute hypoxia and the brain, okay, hypoxia rather than ischemia, if
Yeah.
just pick out the word. So if baby's brain is hypoxic, the variability will go off. Now, the problem is that the heart rate is being slowed down by the brain, which means that if the baby's brain continues to be hypoxic, even if the heart rate starts going up, that is not a sign of improvement if the variability is flat. The variability needs to come back for you to realize that the brain, the hypoxia is getting better. If the variability is still flat, the problem is that the parasympathetic is now switching off. Parasympathetic has no tone. Remember, we said that parasympathetic only has responses. So the baby has a prolonged deceleration because of the parasympathetic slowing the heart down, because of the prolonged cord compression, or because of the hypotension. If the baseline just seems to be floating back upwards with a flat line, that's not acute hypoxia getting better. Acute hypoxia gets better, variability has to improve. That's the parasympathetic getting relieved, rather than becoming completely flat and now it's floating back to where it initially was, because there is no parasympathetic anymore. There is no protective mechanisms acting because the baby's brain is that hypoxic.
But so, at this point, what you want is the heart rate to be up.
Yes, with a good variability, not with a flat variability. So the problem is sometimes people see that the variability is completely gone. They give a terbutaline, and then they watch, okay, terbutaline has just stimulated the heart to become a bit more tachycardic. So the heart rate that was 60 is now 80, but the variability is completely flat. Mm-hmm. And they're just watching because, oh, the baby is improving. We keep on watching. And then they realize 5-6 minutes later that actually, no, the baby was not improving. There was no signs of improvement at all. The baby's actually really hypoxic still. And now they've lost valuable time. Does that make sense? Guys, are you still following that? The rest of the team?
Yes, we are.
Who is on the call? Because I can't. Who is on the call?
It's Kat, Sarah, and Anjali.
Okay, very good.
And Adam, of course. And Pat on the other side.
And Pat,
on the other side as well. Yeah.
Okay, very good.
So what I'm trying to say is that acute hypoxia, with it improving, the baseline is the variability is gonna improve, and then the baseline comes back up. If the baseline is just floating up because you've just given terbutaline, and the variability is completely flat, don't take that. Don't be reassured that that's, oh, that baby's happy now. No, it's not. It's actually still struggling. Okay, so that's the further point from the management for acute hypoxia. Does that make sense? Yeah, guys?
Yeah, no, absolutely. Yeah.
Okay. So we talked about it. It's called the 3-minute rule because we make the call within the first 3 minutes, diagnosis and decision within the next 3, treatment 3 minutes, and we reassess in 3 minutes. If it's an irreversible cause, the 3-minute rule does not apply. If it's irreversible or there's poor reserve, the 3-minute rule does not apply. Deliver this baby as soon as possible. Okay. Any questions about acute hypoxia?
I want to ask you guys, because I think that one of the things that we should be on another step. We should be preventing acute hypoxias. That is our next step. We're not treating acute hypoxias, we're preventing it. Because as Ahmed said, 90% of the acute hypoxias is us. Yeah? So I think I would stress that make sure that you have in your mind that the first thing that you need to be thinking is this reversible or irreversible? Because that's what saves babies, is not messing around with scans and looking for the heartbeats and FSCs when clearly, you know, the variability is completely flat, the CTG was awful before, or it was infective, and actually this baby is going to a terminal bradycardia. Yeah. So, and I've seen this in, you know, risk cases from other places. That's the first thing. Then in a place as Kingston, we want to be ahead. So you know what causes babies to shut down. What I want to be doing is our next step is actually to prevent reversible causes of acute hypoxia. And that's very simple. It's overuse of Synto. It's epidurals where the mum is saying, I feel flushed or I feel nauseated. And we, instead of immediately thinking that she's having a hypertension episode, we'll wait until the baby crashes. Yeah. So it's a little bit thinking ahead. Okay. This, sorry, Ahmed.
No, it's okay.
Continue.
Okay. Any questions about acute hypoxia before we move on? Okay. So subacute hypoxia. Yeah. Subacute hypoxia is the baby spending more time responding to hypoxia than at the baseline. For novices or for people who are using physiology for the first time, we say that baby is spending more time doing decelerations. But as we are more experienced, we understand that it's not just about decelerations, because partial cord compressions can stop the oxygen going to the baby. In general, so this is a case that actually was picked up by one of the student midwives. That's how it came to my attention. So lady was a primary gravida. She was completely normal, low risk at booking, had a CTG because they just put her on an epidural. That's the entire thing. Okay. And she started noticing that the contractions are becoming more frequent, and she could see that these were not, so this baby is accelerating, and she looked at that and she said, these are partial cord compressions. And if you look at this, the baby's spending almost no time at the baseline. So she came up to the ST1 and called him into the room to make sure that, okay, am I just making this up? Okay. Within the next 20 minutes, you can see, so the baseline started off here at 140, 135. Literally within the half an hour that they are calling, can you see where the baseline's gone? Can you see that?
Yeah.
That's all within half an hour. Literally, just because those partial cord compressions that we were not paying attention to, they were significant. All she had was a terbutaline round about here. And you can see by the end of the trace that the baseline is literally just coming back down again. Can you see that?
Yeah. So
that's why the definition is spending more time responding to hypoxia, regardless of what the hypoxia is. Okay, sorry, regardless of what the response is. It might be decelerations. It might also be the partial cord compressions. The pH drops at a rate of 0.01 every 2 to 3 minutes, so slower than the acute hypoxia, but still significant. The idea is that the baby is not getting enough time to refresh the oxygen stores. Okay, so the placenta is not getting the time, hence the baby is not getting the time. It might be that the placenta is fine, but the baby is getting cord compressions. I've told you all about the baby that I delivered and found that it actually had the cord in its hand, was literally just squeezing it. Literally goes into a spasm, squeezes it, and then faints, so lets it go. The moment it wakes up, squeezes it again. Crazy baby. But that was That was the only interpretation of the trace. And when I delivered, it had two loops wrapped around its hand. So the idea is you have little time for the baby to refresh. So how do you manage it? Make the time count for more. Okay, you diagnose it by, we said, baby spending more time in decelerations. How do we preempt the diagnosis? Prevention is better than cure. If you're noticing that the contractions are getting more close together, so they're less than 90 seconds apart, you know that the baby, even if it's fine right now, it will start going into trouble. And be very, very cautious when you start seeing the exaggerated variability, because that basically means baby's going into panic mode. Does that make sense? Okay. So if you're getting prolonged contractions or you're getting increased tone. So how do we manage? We said we have little time for the baby to recover. Well, we try and give baby time, so we reduce the contractions, or make the time count for more, so improve the perfusion. Reduce the contractions. If she's running on Synto, stop it or slow it down. Okay, improve the perfusion. The first thing, always think, get her off her back, or get her off the position that is making her decelerate like this. Find the position where the baby's happiest. Okay. The hypoxia is not resolving, you tokulize. Okay. Especially in second stage. Don't be afraid to give terbutaline before you start pushing. Okay. Don't rush into this. If baby is already starting with subacute hypoxia, whatever you're gonna do can potentially be more damaging simply because you're rushing. There is no pressure as such. Okay. Tokulize. And this is the
in the second stage, ask just them, Ahmed, because in the second stage, before they think about terbutaline, there's another trick that they should be able to use.
Stop the pushing.
Let them ask, don't tell them.
Yeah.
So that they know.
I've grilled them too much for that. So most of them have heard this grilling too many times before. But yeah. Reduce the pushing.
The problem is that I don't see it happening on the shop floor. That's the thing. We need to work to translate the teaching to the shop floor, please.
Okay, you guys need to answer that now.
Okay, just continue, sorry.
Okay, so if she's in the second stage, reduce her pushing. So stop her pushing until the baby settles, and then you can push with every other contraction. There's been quite a few traces actually that delivered this way over the last 2 weeks, by the way, just because I'm keeping eyes on traces for discussions. If this is not working, obviously you still deliver. If you've tried everything and it's not working, the baby's still in subacute hypoxia. This baby is becoming acidotic quite fast.
Unless at Kingston, the baby has a stand clip on his head. Is progressing, yeah, and you have, if you have a second stage and a multip, you can have this subacute hypoxia without any problem if the head is progressing, advancing, and you have no STAN events. But this is, you need to understand what you are looking at, yeah. So STAN is another level of confidence, but you still need to understand the level of stress that the baby is up to. Make sense? So if you have a STAN clip on the baby's head and the baby started well, you start the STAN when the baby is well, you don't need to do an instrumental delivery because of a trace that looks like subacute hypoxia. If the birth is imminent, just let it happen. You don't need to interfere. Do you agree?
So that was going to be my next question, but yes, that's fine.
Do you agree, guys? Because that's, I'll tell you, we have introduced STAN. I did convince the trust to invest £300,000, and we have not shown any decrease in cesarean sections or instrumental deliveries for suspected fetal distress. Go along.
So the question similar to acute hypoxia. What are the signs that the subacute hypoxia is getting worse? And what are the signs that the subacute hypoxia is improving? We're starting with subacute hypoxia. You can see the baby spending little time at the baseline. What are the signs that the subacute hypoxia is getting worse?
Baseline might go up.
Baseline rate going up? Not necessarily, because the problem here is that things are happening quite fast. Baby doesn't always have time to produce adrenaline. So not necessarily. The baseline is not necessarily going to go up.
This is a very, very important point, guys. Really, really important point that in the beginning people get wrong. Subacute hypoxia can happen at any baseline. Yeah, any baseline. Because the stress is too quick and too intense to allow the baby to have capacity to compensate. So the way to compensate is just to decelerate. Yeah. So if you have subacute hypoxia on top of a gradual evolving hypoxia, you will have subacute hypoxia at a high baseline if the baby had released catecholamines already. But if it started quickly, like too much symptom on a trace that is at a normal baseline, it is unlikely that this baby will push the baseline up during the intense stress. Because too much intense stress is not go up, it's go down. Yeah?
So the signs of it getting worse are baby's going to spend even less time at the baseline. So that means that the contraction is getting more intense. Or the variability during the deceleration is becoming abnormal. So you notice that the variability during the deceleration is becoming completely flat or becoming super exaggerated. Both of those are signs of the baby, the subacute hypoxia is actually getting worse. Now, the problem is, what did we just say the treatment was? We stopped the Synto and we've just given terbutaline. Well, terbutaline is going to bring the baseline up. And then people start panicking because, oh, the baseline is now going up. The trace is actually getting worse. No, not necessarily. The baseline has just gone up because of the terbutaline. This baby did not have adrenaline to start with. Unlike the gradually evolving hypoxia, when we said when we give terbutaline, the baseline shouldn't go up. This time the baseline can go up. That's not a problem. The first thing that you start noticing is that the baby is spending more time at the baseline. That's your first sign of improvement. And the variability that's super abnormal is either now only exaggerated, no flats anymore for a while, or actually getting back to normal. Does that make sense?
Yeah.
So baby spending less time at the baseline and it's getting less and less, that's a sign of worsening. Baby's variability during the deceleration is getting more hypervariability or flat, that's a sign of worsening. You give terbutaline, the baseline will go up most of the time, but your signs of improvement is that the baby is now spending a little bit more time at the baseline. Okay? During acute hypoxia, during subacute hypoxia, there is no such thing as cycling. Nobody will ever fall asleep during any of this event. If baby goes flat, this is the baby blacking out. This is fainting. Yeah? This is brain hypoxia. Does that make sense? Okay. We're starting to run out of time. So gradually evolving hypoxia, there's not a lot of things to be said about it. We always say it's the most dangerous because it's the most, although it's the most frequent, it's actually the most missed. And the baby has time to give us signs of it getting worse. So it starts off with a normal trace. Okay, I'm just brushing through this a bit. We start getting some decelerations as response to hypoxic events. And then the deceleration gonna become more frequent. They then start baby starts losing its cycling. So it's not gonna fall asleep because of the events that are happening. They are becoming more and more intense and baby's not gonna fall asleep with that. As it gets much worse, then the baby starts redistributing, and it does that by secreting catecholamines. Once it starts producing catecholamines, the first thing that happens is that the baseline goes up before any redistribution actually happens. The first thing is always a rising baseline. That's how our heart responds to any adrenaline, a bit of tachycardia. Okay? And as the baseline goes up, then the periphery starts going into vasoconstriction. And the vasoconstriction of the periphery is why the decelerations get even deeper with the cord compressions. Because if you remember from last time, we said that during a baroreceptor cord compression, the arteries are blocked, which means that the aorta is going to fill up with all the blood that comes out of the heart, and there is nowhere for it to go, because 40% of the cardiac output has just been blocked. It has to wait for the blood to just make its way into the peripheral tissue. But you've already done vasoconstricting the peripheral tissue, so there's nowhere for the blood to go. So it has to slow right down, and has to stay very slow until the blood literally leaks into the brain. The brain and heart consumes the blood. That's why the decelerations become deeper. And the redistribution in itself, we can't see anything else on the trace. There's nothing that we can see throughout the process of redistribution apart from a high baseline with deep decelerations. Okay, until we reach the point of brain becoming hypoxic, and then the responses start fading out and the variability starts going away. And then we go into heart failure. Okay, we talked about, or we always say how all of the steps are reversible. Even some brain ischemia or hypoxia is still reversible. Baby can still recover from that. But if it goes into terminal heart failure, there is no coming back from that. There is no way that baby can recover, because baby's brain, the protective mechanisms, have completely stopped. Okay? Now, the issue is that with gradually evolving hypoxia, this episode, so once the baseline has gone up until the decompensation, there is nowhere or no way for us to see the changes. There is no way of knowing what parts of the baby has gone into ischemia. And that's where STAN comes in, because STAN is focusing on the anaerobic metabolism within the body and the heart, and it's looking at the heart ischemia and brain. So STAN starts alarming to prevent you from reaching this point. You don't want to be reaching this point. So yes, we said that some brain ischemia can recover, but why would we do that? Why would we go all the way into blacking out and then hope to try and recover? It gives us very little time, and it's a very stressful time. But the reality is we are trying to prevent the baby progressing along this path, along the redistribution path, as much as we can. But if STAN starts alarming, this is becoming urgent, because the ischemia or the redistribution is reaching the level of the brain and heart. Does that make sense? That's why STAN is your safety mechanism. You're trying as hard as you can to make STAN not alarm. But if STAN alarms, and you can see that we've reached a point of catecholamine response and redistribution, this is really significant. Are you following me there?
Yeah.
But if we manage the CTG well, then actually we're never going to prove that STAN is an effective intervention, because we're trying to prevent the STAN alarming in the first place.
Yeah, I'm not trying to make it alarm. You're not going to convince me to make it alarm, Adam.
No, me neither. I'm not trying that. But I agree. Susanna loves to say, it doesn't look like she's there now, but she loves to say trust STAN. But actually the key thing is to be able to manage it so that actually you don't get a STAN event, right?
Which is why what I'm saying is that you're trying to prevent it all the way. You're trying to make STAN not alarm. You don't want to reach the point that STAN is alarming.
I think we should all have 2 strikes, and we're not allowed to have STAN events, all right? Each trainee has 2 strikes, and you're not allowed STAN events, right? If you get one, valid one, then that's 1 strike. 2 strikes, sorry man, you're back on gynae.
Yeah, okay. Well, yeah, we can present that. I mean, too bad Susanna's gone now, so.
Quality improvement project, yeah.
What she was saying though, that we've not had any reduction in cesareans or instrumentals because we're not letting the
we're not trusting STAN enough. So that's what she's saying. What Susanna's trying to say is that people are panicking too early on. So they're panicking once there's a rise in baseline. Okay, you still have a lot of space and leeway there. Okay, there are 2 ways that you can look at this. You can either actually take a deep breath, slow her pushing, stop her pushing, give her terbutaline, do all of that, okay, and then start. Or you can start panicking and have to deliver this baby now, with a high head, that she's not yet started pushing, she's not that experienced, she's not going to push that well, you're going to end up with a cesarean section.
Yeah.
So the reality is, as long as Stan has not alarmed, you actually still have time to improve the trace. If Stan is alarming, you still have time to improve the trace, but that's not very long time. You have 20 minutes to make a significant improvement.
Yeah, we need to do more
from a Stan event,
rather than just rushing and cut the
deliver
kiwi on,
babies.
on the grand multi, yeah.
yeah.
But the ST1 needs it signed off, so.
Well, I'll leave that to you, Adam.
I didn't mean Maddie, but Maddie is the only ST1, but yeah.
So your aim is to improve the baby's condition, especially if there's signs of redistribution. And if there are signs of decompensation, you actually need to reverse them immediately or deliver. Yeah?
Yes.
Okay. Adam, I've already eaten 5 minutes into your presentation. Just give me
My
4.
presentation is 7 minutes maximum.
7 minutes. Okay, in that case, I still have another 5.
Yeah, take your time.
It's your moment.
I'm going to start from the end.
Chronic hypoxia, interestingly, is the part, or is the type of hypoxia that I think we've made the most significant improvement upon. Not because we're treating it, just because we're recognizing it more. So we've actually started recognizing more babies with chronic hypoxia. And chronic hypoxia is the damage that causes or that comes back from most of SIs and most of court cases that I've ever been asked to give an opinion on. Okay? It's a hypoxia that develops antenatally, and the baby starts its journey already on the hypoxia stage. 3 cardinal signs: high baseline, reduced variability, and shallow decelerations. Okay? Reduced variability usually comes with no cycling, so this baby is not going to be very active. It's not going to be, she's usually going to be complaining with reduced fetal movements. Okay? Although not necessarily. Okay? Shallow decelerations, if the baby is becoming, there's something to trigger the decelerations, but the baby is not going to be accelerative. And the very important point to always note, it's a high baseline for this baby. You always have to think about where was the baseline for this baby supposed to be. Okay. Now, chronic hypoxia invariably is caused by placental insufficiency. The placenta along the way has lost a significant portion of its function, hence whatever it's producing is not enough for the baby. Okay, so regardless of the cause, the end result is a reduced oxygen supply to the baby. The spectrum of chronic hypoxia, though, is quite wide, and the first step is reduced reserve. Okay, reduced reserve means that this baby is functioning perfectly fine. She's not complaining of any reduced fetal movements. This baby is perfectly happy. This baby has a normal CTG until there is some sort of stress. That's the time when the reserve actually is tested. When dinosaurs still roamed the earth, we used to do something called a stress test. So women used to come to the antenatal clinic. We used to sit them down, do a CTG trace, and then start them on oxytocin for half an hour, get them to start contracting, and saw what the baby's response to that was. So it's like the stress ECG kind of thing. Get them to work and see how they respond. Okay, but that's obsolete now. We stopped doing that. Many women started going to preterm labor. Many babies that actually had chronic hypoxia started getting damaged. So we've stopped doing that. But obviously, it was a test. At this point in time, the only time when you do this test anymore is in early labor, late phase. When the baby comes in, or she's contracting, or when you're inducing. She comes in, she's perfectly fine when there's no contractions. The moment she starts contracting, the trace starts showing changes. That's what tells you where reduced reserve is. Okay.
Can I add something, Ahmed?
Yeah.
So we have a tool that can help us a little bit on that. What it is? Hey guys, tell me. Because Ahmed is very right to say, so there's a bit of false negative for CTG with, I'm speaking about antenatal CTG, with babies that are in the initial phases of chronic hypoxia. It means that they have very poor reserve, but they are not showing yet, you know, the chronic hypoxia typical signs on the CTG. Because when you have chronic hypoxia on the CTG, you know that that baby's not going to cope. Yeah. So what is the other tool that we have, not from the dinosaur time, like the stress test, that we have that can give us a little bit more information than the plain CTG?
The Dawes-Redman criteria.
The Dawes-Redman criteria. Okay, the Dawes-Redman criteria. And I can give you by, you know, last week we had a term baby that didn't meet Dawes-Redman. And the CTG, I tell you, and a naked eye was looking pretty normal. And I went to do a scan, and that baby had abnormal Dopplers. Yeah. So Dawes-Redman is kind of a, for the antenatal CTG, a step ahead in this placental insufficiency, poor placental reserve story. Yeah, please continue, Ahmed. Sorry I interrupted.
Okay. No, it's okay.
They're going to hate me.
No. No. So if the placental insufficiency is getting worse, that's only when baby's growth starts getting affected. It means that baby's lost all reserve and it's now reached the point that it can't grow anymore. Yeah? If it's getting even worse, then we start redistribution. So redistribution again is always facilitated by catecholamines, and the baby would have a higher baseline of catecholamines being secreted. And the first thing that happens with catecholamine secretion is, sorry, it would be a relative tachycardia. Baby's heart rate would be beating at slightly higher rate than what it used to be. And then redistribution starts, following exactly the same protocol or pathway that it used for the gradually evolving hypoxia. Okay? And it can even reach heart failure and stillbirth. Chronic hypoxia is always about thinking hypoxia or thinking chronic hypoxia, because the babies that come with reduced reserve, yes, many of them would complain that they're not moving very well or reduced fetal movements, but actually the majority complain of absolutely nothing. They're absolutely fine. There's nothing at all that they're complaining of. But once they start contracting, you start showing the gradual evolving hypoxia pathway. Okay, and because they have reduced reserve, they can actually jump between steps fairly quickly. Okay, how do we diagnose it? We've just talked about it, and most of you know about the checklist for the admission for the baby, checking what the baseline is. You're literally just looking for the cardinal signs. Baseline, whether variability is normal and cycling is there, whether accelerations are present, shallow decelerations, or anything else going on. Okay, so this is an important thing I want to talk about. Now, we always talk about types of hypoxia separately. Yes, we always talk about this is acute hypoxia, this is how to diagnose, etc., etc. This is subacute hypoxia. The reality is that obviously they are interchangeable. Nothing stops a baby that is running through gradually evolving hypoxia from suddenly having a prolonged contraction and ending up with acute hypoxia on top. Okay? Your backbone for any type of hypoxia is pretty much the gradually evolving hypoxia pathway. That is your backbone. Okay? So most babies, unless they have chronic hypoxia to start with, they end up with some evidence of hypoxia and things start getting worse from there. And most of the time, babies do not jump steps. They will follow the steps along the way. However, if the hypoxia interchanges, so let's start with a baby that has gradually evolving hypoxia, it's showing some decelerations, it's lost accelerations, and suddenly now it's gonna go into subacute hypoxia, okay? It's gonna have, what, 10, 15, 20 decelerations before we even pay attention, another 10, 15, 20 decelerations before anything else, before we manage to improve it. this baby can jump a step. So it can end up with decompensation before it ever gets the chance to secrete adrenaline. That's why I said if subacute hypoxia is getting worse, the first thing that you're going to notice is that the variability is going to go off. Baseline is not necessarily going to go up. And once you reverse the subacute hypoxia, it will actually start from this step, which means it jumped a step. Does that make sense? So be very, very cautious because they do interact. Any questions?